Hello, and welcome to the channel. Today we want to look at the respiratory system, and we want to look at how we can use drugs to make some changes in this system in terms of management and treatment of some diseases. This will be our outline. We'll look at the system itself. We will look at some general signs and symptoms of disease of the system. Then we will look at classes of drugs that we can use to affect this system. Then we can finally look at some tips to take care of your lungs. So let's zoom into that. Let's talk about the respiratory system. There are two ways by which we can describe this respiratory system. We can describe it anatomically, and when we do that, there are two sub-ways by which we can look at it. We can look at the upper respiratory system and the lower respiratory system. Now, in this instance, if you look at our diagram or picture here, you see that the top part from the shoulder upwards, the nasal cavity, the pharynx, and the larynx are what we're referring to as the upper respiratory tract. Then the part below the shoulder, basically the trachea, the bronchia, the bronchioles, and the lungs, they form the lower respiratory tract. So that depending on the anatomy, we can describe diseases as upper respiratory tract infections or diseases and lower respiratory tract diseases. Now, all this one way we can describe it, all these parts in the system can be affected by diseases. Then we can also look at it through its function. And again, in the functional way, we also divide it into two, where we look at the conducting zone, which is basically the zone through which there is the flow of gases, but there's no exchange. So in other words, this includes your bronchia, beginning from the nose as you go through the bronchial, down all the way through the bronchioles, the smallest part of the bronchial, that forms the conducting zone. This zone is not involved with gas exchange. Gases pass through this, but there's no exchange of gases. Then the terminal point, which is basically the alveoli and the alveoli duct. This is where the beginning of the ending of your bronchiole, the beginning of your alveoli, and the alveoli itself forms the respiratory zone. This is where gaseous exchange occurs. Gases are exchanged. Oxygen is exchanged for carbon dioxide. So that is the respiratory zone. So in other words, when we talk about the respiratory system, we can look at it through its anatomy and we can look at it through its function. And in both ways, we can look at two subdivisions. Now, if we look at the system as a whole, every part of the system can be diseased. So when we mention these parts, we started with the nose and we said as you move down, pharynx, larynx, as you go down all the way to the alveoli, any of these parts can be diseased, and there are various diseases spreading through the system. We can think about infections, we can think about inflammations, we can think about so many diseases that can occur. Now, here are some examples of such diseases. So if you take the nasal cavity or the nose, we can think about a nosebleed. We can think about a runny nose. We can think about common cold. If you take the pharynx, which is the throat, you can think about inflammation of the throat, pharyngitis. This could be infected. So you can have infected pharynx, which is also described as pharyngitis. You can have a cancer of the throat. You look at the larynx or the voice box, there can be inflammation or infection. You can look at the paralysis of the vocal cord. Then you take the trachea, in the same way you can have inflammation, infection, tracheitis. You can have stenosis or narrowing of the trachea. And so the point of this slide is to say that every part of the system, from the nose right down to the alveoli, can be infected, can have some form of disease, some form of disease. Now, here's some clinically important diseases as far as the respiratory tract system is concerned. The first and probably the most known is asthma. Asthma. Now, asthma is primarily a situation where the airways, which is basically the conducting zone, the muscles of that airways is experiencing involuntary movement or spasms. Now, these spasms lead to the tightening of the airways, sometimes, in fact, leads to swelling and inflammations of the airways. This tightening is what results in the symptoms that we see with asthma. The inflammation is usually the underlying reason for this tightening and swelling. So asthma is one of the most important clinical diseases of the respiratory system. Another one is the chronic obstructive pulmonary disease. Now, this is not one disease, but a cluster of diseases. It's just a name given to a group of diseases, and it includes inflammation of the bronchi, which has become chronic, or trachea, which has become chronic, or even emphysema. Emphysema is where the airways is damaged, or the alveoli is damaged, or even both can be damaged. Now, that's emphysema. That's also described as chronic obstructive pulmonary disease. So that term includes a group of diseases. You can also have cancer. So the lung cancer is another clinically important disease of the respiratory system. And then you can have fibrosis, cystic fibrosis. Now, cystic fibrosis is where you are having thick mucus being formed in the lungs. This can actually lead to low levels of oxygen, can actually lead to blockade, and sometimes can result in death. Now, this is actually a disease that is you may be born with, is something you may inherit, but it is really life-threatening, and it can result in damages to the lungs. It's not only the lungs that can have fibrosis. Fibrosis can occur in other parts of the body, including the digestive system. Then we can have infections of the lung or the airways or the sac, which is the alveoli, and that is described as pneumonia. So depending on the type of infection, if it's bacteria, it's bacterial pneumonia. If it's viral, viral pneumonia. Fungal pneumonia, etc., etc. But basically, it's talking about infection of the lungs. Infection of the lungs. So you notice that there are various diseases that occur in this system, and therefore this system is a very important system for us, and we need to understand some of these things. Now, there are some signs and symptoms that point us to diseases of this system. So we want to look at a few prominent ones, which once we see, brings our mind to the fact that there may be a disease of the respiratory system. The first one is cough. Cough is a major symptom, a major sign of disease of the respiratory tract. Then dyspnea, and then pain in the chest. There can also be other symptoms like wheezing, fatigue, malaise, headaches, clubbing, and inability to engage in physical activity. In other words, you decline in your physical activity per time. You see that there's a declination, it's going backwards. You can't continue to do. So today you're able to do 5 minutes. After a while, you will now be able to do only 3 minutes. It just shows that you are going backwards. You are not making progress, but declining. And that is a symptom or a sign of disease of the respiratory system. But the most important, the major ones are the cough, dyspnea, and the chest pain. And these symptoms point us or guide us into knowing some of the diseases that may be in this respiratory system. So, for example, if we take a cough is described as a particularly important sign of all diseases that could affect the system, the respiratory system. And there are two types of cough. And these two types of cough help point us in a direction of what diseases could be present in the respiratory system. So when you take a wet cough or a productive cough, which is cough that is accompanied with sputum, when there is a productive cough, it tells you there could be an infection. And we've already stated, especially bacterial infection. There could be an infection, which we describe pneumonia as infection of the lungs. It could be an infection of the bronchi. It could be an infection resulting in chronic obstructive pulmonary disease. So infection. It could also point us to inflammation. And again, inflammation, this time there's inflammation without infection. So COPD or bronchitis, etc., can also be. It could also point us to the sign of allergies. A person allergic or responding to something allergic may produce wet cough. And then it can also tell us there is cystic fibrosis, or it could tell us the presence of a malignant disease. A malignant disease. We should note that for children, when we think about infections, normally we think about viral infection and we think about asthma. The primary infection that we look for in children is viral infection. And if it is not a viral infection, it could also point you to asthma. What this means is this. If a child is producing productive cough or a wet cough, a child is coughing and it is wet, it is productive. You don't first, if you are even suspecting infection, you don't first suspect bacteria because for children, mostly it is viral infection, which means they may not need antibiotics. So you don't have to quickly write a prescription for an antibiotic. You don't have to quickly want to prescribe antibiotics. If it is viral, it is self-limiting. All the child needs is some rest, a lot of fluids, and that will go off. Or if it's something that is chronic, something that persists, something that continues to come, you may want to investigate further to check if it is not asthma, because it could also be pointing you to asthma. So that is productive cough. Now, if the productive cough comes and there is blood in it, the presence of blood in the sputum is a very important sign. It could simply mean that, well, the person has been coughing for a while and maybe capillaries have been damaged. That is simple. That is easy to see. But it could also point to a tumor. So you have to make further investigation, or it could point to probably an infection that has been there for a while, that has been exacerbated. So the point is, if you see blood in the sputum, there is a need for further investigation. And tuberculosis, for example, a classical sign of tuberculosis, an infection of the lungs by Mycobacterium tuberculosis, is blood in sputum. Technically, blood in sputum is known as hemoptysis. So hemoptysis is a classic sign of tuberculosis of the lungs. So never disregard hemoptysis if you see it. Never disregard the sign of blood in sputum. Once you see it, there's the need to ascertain why you are seeing the blood and take remedies that are necessary or that are important. Don't play with hemoptysis. The second type of cough is described as irritative or dry cough. Dry cough because there's no sputum accompanying the cough. Now, this type of cough, dry cough, is described as painful and is described as difficult to control. A dry cough or an irritative cough will point you to either an inflammation in the case of asthma or inflammation of the tracheal system. So it could be tracheitis, it could be laryngitis, it could be bronchitis, inflammation. Or it could also tell you there's an irritation. Something is mechanically or physically irritating the system, the respiratory system. Sore throat is a typical type of a typical thing that produces irritative cough. GERD, gastroesophageal reflux disease, can also result in irritative cough. As important, we have said that irritative cough can be difficult to control. We have medications that help us with irritative cough, but note that they can be difficult to control. And then there is this class of drugs, ACE inhibitors, angiotensin converting enzyme inhibitors, normally used for hypertension and other cardiovascular conditions. These class of drugs we describe as the pills. So you see the examples over there, lisinopril, enalapril, captopril. These we describe as the pills. These drugs work by inhibiting the enzyme angiotensin converting enzyme. It's been known that these drugs can cause irritative cough or dry cough in some patients. And that is because the enzyme, angiotensin converting enzyme, is also found in the lungs. And once these drugs are administered, angiotensin converting enzymes are inhibited in the lungs. In the lungs, these enzymes are responsible for the breakdown of bradykinin in the lungs. But once they are inhibited by the drugs, the ACE inhibitors, you will note that bradykinin begins to build up in the lungs. The buildup of bradykinin in the lungs is what causes the irritation and leads to the dry cough that is produced as a result of ACE inhibitors. When a patient experiences dry cough, it's important to stop the ACE inhibitors and go on to use their sister agent, the angiotensin 2 receptor blockers. So we should, very important to note, dry cough is a limiting factor for the use of ACE inhibitors. ACE inhibitors. And that's also important to note. So especially our elderly who are on chronic drugs, if you see an elderly coughing, you want to make investigation to see maybe if they are having some ACE inhibitor among their drugs, and that could be the reason for the dry cough. Again, you note that these type of dry cough do not respond to normal cough medications because the issue is a buildup of bradykinin and not just an irritation, but there's an underlying reason for the irritation. And until that is taken care of, this person may continue to cough. The good news is once you withdraw the ACE inhibitors, the angiotensin converting enzymes are released and they can go back and break down the bradykinin, and the cough will cease by itself. Okay, the second symptom we said is dyspnea. Dyspnea, which is described as difficulty in breathing or labored breathing, or you can also say shortness of breath. Dyspnea. Normally, this can also be accompanied with pain. Dyspnea may point us to asthma, or it may point us to damage to our alveoli, which is emphysema, or it could point to thick mucus being formed in the cystic fibrosis. So dyspnea is the second most important symptom and sign that points to respiratory tract disease. The third most important is chest pain. Whenever you experience chest pain usually points to infections. So once you're experiencing chest pain, the first thing you normally check for is investigate for infections. But also, chest pain could be an early symptom of lung cancer. So once you have chest pain associated, it could be, these symptoms and signs we've talked about can come together. You can have your dyspnea with your chest pain, or you can have your cough associated with chest pain and dyspnea, and vice versa. These symptoms can be alone or they can work together. But the idea is whatever you see, it helps us to look in the right direction so that we can help our patient. Now let's look quickly at some drugs that we use for this system. The first class of drugs are referred to as bronchodilators. From their name, we know that these drugs are going to be opening the airways, the bronchi, and they do so by relaxing the muscles of the bronchi, of the airways. These drugs can work by opening the airways. They also help relieve the symptom, especially like dyspnea, that the patient may experience. So we use these drugs in COPD conditions. We use it in asthma, especially. There are three main classes or subgroups of these bronchodilators that are available. The first one and the most popular is the beta-2 agonist. The beta-2 agonist. These work through the beta adrenergic receptors, and they activate these receptors that leads to the relaxation of the muscles of the airway, that leads to the opening or the widening of the airways. Examples of beta-2 agonists include salbutamol, salmeterol, formoterol. They have different duration of actions, and so depending on how long you want the drug to act, you may choose the appropriate agent. The second class of drugs is the anticholinergic agent. These working through the muscarinic receptors of acetylcholine, cholinergic receptors that are described as muscarinic. Because of that, we can also describe these anticholinergic agents as antimuscarinic agents. Examples include hypertropium, tiotropium, etc. Now, these groups, we use it especially in people who have some form of compromised respiratory system or compromised respiratory tract. For example, chronic smokers. Anticholinergic agents are preferred in chronic smokers, chronic abusers of nicotine. In those instances, beta-2 agonists can work, but they are not the preferred choice. They prefer the anticholinergic agents because they have a more lasting direct effect at the muscle site through the neurotransmitter acetylcholine. There is the third member, which is theophylline. Among the three, theophylline is the weakest of them. It is also used mostly in over-the-counter medications, and it has been used, like the others, for asthma and COPD. So in this instance, you will notice that beta-2 agonists are the preferred choice for asthma, and for COPD, the preferred choice mainly is the anticholinergic agents. Anticholinergic agents. A second class of drugs that we want to look at are the corticosteroids. Corticosteroids. Now, these are steroids that are used as anti-inflammatory agents. So they are also described as anti-inflammatory drugs. Now, we talked about inflammation underlining both the cough, like wet cough, or even dry cough, asthma. Both can be having inflammation as an underlying reason. These group of drugs, corticosteroids, work by reducing the inflammation or by inhibiting the processes that lead to the inflammation. In this way, because they help reduce the inflammation, they help one take care of the underlying reason for the problem. And they are used thus for repair and they are also used as a means for maintenance. Now, because of this, they are usually used together now with the bronchodilators. The combination of a bronchodilator and corticosteroid is now the best choice for managing of our asthma and for COPD. The combination, first, the bronchodilators give quick relief, and the corticosteroids help with maintenance and repair.